Hello everyone, I am Dr. Nikunja Gujarathi. I am an assistant professor at Sanjeti College of Physiotherapy. Today we'll be talking about pressure ulcers. So what are basically pressure ulcers? Pressure ulcers are nothing but a damage in the layer of the skin which is caused by frequent and continuous pressure over that is loss in the integrity of skin. Now let's move forward and understand how this happens.
Understand how a pressure injury is formed, let's first start by learning about the skin. Let's assume this is the bone, above which there is a muscle, following that subcutaneous tissue. Then there is blood vessels. These blood vessels supply your dermis and epidermis. This is your epidermis, this is your dermis. Okay. Now, when a patient has been in a supine position, or let's say any dependent position for a long period of time, what basically happens is the body weight of the patient, or there is pressure from the above which is pressing on the bone. So this pressure for a very long period of, there is a pressure for a very long period of time, which in turn obliterates the vessel. This impingement of the vessel causes the ischemia and further on necrosis of your dermis and your epidermis. There is another way in which this injury can take place. Supposedly a patient who is not very conscious has been put in semi-Fowler's position and is not able to hold that position and slips down off the bed continuously. As he slips down, the skin moves in one direction, whereas the bone tends to move in another direction, posing a shear force on the blood vessel. This shear force again obliterates the blood vessel, causing ischemia and further necrosis of your dermis and your epidermis.
Break. Can be also caused by a medical device like a nasal prong, which supposedly is placed here near the ear. And if the patient is in sideline position for a long period of time, they could have an abrasion here, and this could cause a wound. This is very commonly seen in babies mostly, which are there in the ICU. Another thing which we need to see is what are the risk factors associated with pressure ulcers, like what causes a pressure ulcer to happen more frequently. First is poor nutrition. A patient who is on maybe parenteral nutrition or is not able to take feed, is poorly nourished, malnourished, is more likely to have a pressure ulcer. Another thing, poor hydration. Then incontinence. Any wound, if the area is more wet, is going to cause a more bigger problem. So that is why incontinence, there are more chances of bedwetting and all of those things, and hence people at incontinence are at a higher risk. Diabetic patients, because of their sensory issues as well as circulatory issues and delayed healing, they are at a greater risk of pressure ulcers. Coming to next part is immobilization. Immobilization, patients with spinal cord injuries or any other comatose patient, any other patients with neurological condition which makes them prone to rest or make them prone to bed rest are at a higher risk of developing pressure injuries. Now let's see where are these injuries most likely to happen. So the most common places are supposedly the patient is in a semi-Fowler's position for a long period of time. So now, as you can see in this chart, the patient in semi-Fowler's position is most likely to develop a pressure injury at the base of his head, then at the back of his shoulder. Another part will be your but base of spine, then your buttocks, your heel, and if the patient's leg falls outwards as he sleeps, then it could also be your lateral border of your leg, of your foot, sorry. Then if the patient is in supine position, let's assume. So if the patient is in supine position, the most common part are your back of your head, that is the occiput part, your shoulder, your elbow, then the buttocks, and your heel. Next is sideline position. In sideline, again, the side of your head, not the base, but side of your head, your shoulder joint, your what you say, side of the buttock, that is your GT basically. The bony prominences which are most commonly present at that part. Your side of the thigh, again your lateral part of the knee, your lateral part of the calf, and your malleoli, medial or lateral malleoli, based on how the leg position is. These are the most common areas which are affected with the pressure sore or pressure ulcers. Okay, so now let's see what do you need to see to understand or to assess a pressure ulcer. First thing is how does the wound look? That means the size of the wound, the discharge that is coming out of the wound, and the last thing that you need to document is what is the staging of the pressure ulcer.
The staging of pressure injuries with the help of this banana. Now, for the first stage, the skin is still intact. There is no breach in continuity of the skin, but there is an area of visible redness which is non-blanchable in nature. When I say it's non-blanchable, it means that the area, even when it is pressed, it does not turn white. For stage 2, there is visible damage with partial loss of dermis. But there is partial loss of dermis, but no fatty tissue, subcutaneous tissue is visible. For stage 3, there is full loss of skin tissue. There is full loss of skin tissue, including the dermis, the epidermis, and the subcutaneous tissue. But still, the subcutaneous tissue is still partially there. For stage 4, there is full loss of skin with visible bone. With visible bone. Now let's understand how to measure the size of a pressure injury. This is one of the steps that needs to be documented while you are assessing a patient. So for this particular injury, we need to assess the length, which is around 3 centimeters here, and then the breadth, which is around again 3 centimeters here. Also, another thing that needs to be measured is the depth of the wound, which can be measured by using a sterile Q-tip or a earbud for that matter. The thing that you need to assess is the color of the discharge. So for first, the color could be serous, or the discharge itself could be serous, which means it is clear, it is transparent, and it usually signifies a non-infectious wound, and it is normally present. Second is serosanguinous. Sanguinous means there is some serous fluid along with a tinge of blood present. This is serosanguinous. Next is it could be completely filled with blood, which is called as sanguinous discharge. And the last, it could get infected and it could be purulent, which means there is pus and it could appear yellow like this. This is your purulent discharge.
Now that you know how to assess a pressure ulcer, let's go and see what can you do to prevent and to manage pressure ulcers. So the most common part that you can do is to prevent pressure ulcer is position the patient every 2 hourly. If you cannot do it, ask the relative, educate the people around the patient to do it. The staff nurse or anybody who is present with the patient continuously can help you achieve this. The second thing can be done is if you are suspecting prolonged immobility, then the surface on which the patient is lying can be changed. That is, either the use of an airbed or a waterbed can be done. With airbed, there are air pockets in there which allow for differential distribution of weight of the patient and help preventing bed sores. So, use of airbed or waterbed can be done. Another thing, use anything at your disposal that you can use to, relieve pressure. For example, there are gel pads which are commonly available that can be used beneath the buttocks. A very common practice is putting water in the gloves and placing them below the ankle to prevent bed sores there. So all of these methods can be used. Again, the nursing, if at all you visualize or you see or you notice a bed sore and catch it early on, please report to the concerned staff, whoever is there. Another thing that can be done is keeping the area dry. You have to educate the family about what is going on, and you need to tell them to keep the area of the bed sore dry as possible. Thank you. Happy learning.